Good morning. This interview is part of a series of communications from Mechatronics related to esophageal cancer. Today we talk to Bob, who lives in London and who went through the so-called Lewis-Santi surgery of his esophagus due to an early stage cancer. The intention is to share his experience and most of all to understand the impact of the surgery on his daily life. So let's get into it.
Yes, Bob, nice to see you.
Good day, nice to see you.
I appreciate that you're here with us in this interview and give us some information about you and your treatment. So the first question I would like to ask you, can you please describe the symptoms you recognized and how and when this esophageal cancer has been diagnosed?
Yes, it's. I subsequently discovered the symptoms I had are absolutely classic, which is I had difficulty in swallowing. It didn't seem that important or significant, but nonetheless, it was an issue. So I, at the encouragement of my partner, I went to the local doctor, who very quickly decided he didn't like the sound of it and referred me for a gastroscopy, which happened within days. The speed of everything was very quick and very good. So I go for a gastroscopy and they establish a 2-centimeter tumor at the very base of my esophagus with the junction of the stomach, adenocarcinoma, in other words. And then I was referred as a consequence of that to the oncologist. I saw them the very same day. And then he explained to me what was on offer, what was proposed for treatment for it.
Okay, thank you. Also, welcome from my side, and thank you for taking all the time.
Thank you.
I have three questions on that. First, was any option suggested to you in terms of treatment, surgery types, or other treatment types? And what were the decision criteria for your operation? And the last and third one, and how were you informed in detail about these consequences?
Okay, fine. I was only really given one option, which was the classic one of 3 months pre-adjuvant chemotherapy, Lewis-Santi operation, and then 3 months, which is bi-weekly for me, chemotherapy post-adjuvant. The first chemotherapy was presented to me as necessary to attempt to shrink the tumor to make the operation more easy, more likely to be successful. And then the surgery is to cut out the tumor. And the post-adjuvant chemotherapy was to inhibit the reoccurrence of any cancers. I also read myself at the time, that was a comparatively low-level possibility. I can't remember the exact figures. I think it's low possibility, but nonetheless, the post-adjuvant chemotherapy has been shown statistically to reduce the possibility of reoccurrence. And in fact, when I got to that point, I'm jumping ahead a bit here, it was more optional for me to do that than the pre-adjuvant chemotherapy. Basically, do you really want to go ahead with this, Bob? And I didn't, because I'd already done 3 months chemotherapy before a major surgery. But I decided every percentage is important in terms of outcomes, so therefore I went for it. I think I've forgotten the second point of your question there, Hilmar. Remind me again.
What were the decision criteria for your operation? Yeah.
I'm pretty clear, subsequently having a meeting with the surgeon, it was, this was just before my 70th birthday, but I'm slim and fit and healthy. And it was an early stage diagnosis. I'm quite sure they saw me as a potentially positive outcome compared to others. And in fact, subsequently during chemotherapy and everything else, my blood tests that went on through the chemotherapy turned out to be very good. And there were people being turned away And as my surgeon said in my preliminary discussion with him about exactly what the surgery would involve, he said I was one of the lucky ones, because in fact many people were turned away because they were not healthy enough or they were too advanced in their cancers to actually make that treatment program viable, valid. So I hope that answers the question. I'm not sure if I have.
And how were you informed in detail about the consequences?
Okay. Having had the meeting with the oncologist, I agreed to go ahead with that treatment program. I was not offered any alternative possibilities. And to be honest, I just went with the flow and the expertise and experience in front of me. I knew nothing of it at the time, so I didn't know if there were any alternatives except to say no and suffer the potential then development of the cancer. So I wasn't given an alternative. I don't know if there is an alternative even now. Excuse me. And that was that. So we agreed to go ahead. And then I went on to meet the surgeon. And he gave me the worst case scenario, which is opening up the chest and everything. And he did a wonderful picture of this is what could happen, which was pretty hairy to say the least. And the outcomes. He was more positive that wouldn't have to happen, but nonetheless, he was being very honest and open about the potentially worst case scenario. So we did not discuss at any point the post-operative possibilities, that things, what could happen. Being me, I'd already researched a lot on the internet. I read a lot, and I knew that there was a 5% fatality at that point in time. We're talking 2016, 2017. But that also depended on the patient and the surgeon, didn't it? And I'd done my own research, and my surgeon came out in the top 3 in France for this particular operation. And when I questioned him on it, he actually told me how many of these operations he did a year. This is not a common operation, and he was experienced. So I was reassured on that point.
So, Bob, you got the Louis Santi operation. Can you explain the surgery from your point of view, and were there any complications after the operation?
That's a big question, Peter. It's the surgery and the aftercare was superb, because it's not just the surgery; it's the post-operation team in the and they were extremely good. I didn't have any particular complications. I had an awful lot of blood still swirling around in my chest, so I had to go down to the theatre again and have that drained off. I should have mentioned, forgive me, there is a month's gap between the chemotherapy and the surgery for you to recover enough to maximize your strength of the surgery, and equally after the operation as well. So I recovered well. It was reasonably straightforward. There were I can't remember complications.
Very good.
So, am I answering the question, Peter? I'm missing?
That's okay.
No,
thank you.
That's okay. What are now the consequences of this surgery on your current life?
Okay. As you all know, this is major reconstructive surgery, and I lost most of my esophagus and the upper third of my stomach. The purpose of that, of course, is to minimize the opportunities for any tests. Do not 100% trace cancerous cells or the potential for them. So they maximize the surgery to minimize the potential for it still being there in the body without being able to find it, as it were. I think that was my understanding. So I lost most of my esophagus and a third of my stomach. This, by the way, I knew was going to happen beforehand. I should have explained if I hadn't already. I already had this explained to me. And the operation, pulling the stomach up to rejoin the esophagus at the top. So that removes sphincters. It removes the control system within the body for preventing acid coming up. And the acid reflux is what had caused my cancer at the very base of my esophagus in the first place. So that was inevitably going to lead to issues going forward. And this was, I was told about this. What happens is that you cannot sleep horizontally. You have to have an incline because otherwise, and you can't, by the way, ever sleep on an incline. You always end up in some phase during the night sleeping horizontally. You just do. Most of the times it's okay, and I can go for weeks, sometimes months without an issue popping up, and others I can have some very bad nights where I do go horizontal and the acid pops up. You are given advice, by the way, about not eating after a certain time for the digestive process, like 7 p.m. or 8 p.m. in the evening. I have found that advice to be comparatively irrelevant. I've eaten late at night with the munchies at 10, 11 p.m. and I don't have a complication overnight with it. As long as I don't eat gargantuan or don't drink lots of alcohol, it seems to be tolerably okay, except if I randomly am a horizontal, then it comes. And it disturbs your night. It disturbs your sleep. The acid is there. And you feel pretty shattered the next day. I end up with a very tired day after a bad night. They don't happen that often, but they happen. I could have had one last night. I didn't. It's always there. It's with you all the time. During the daytime, not a problem. You're vertical. That's not an issue. Sitting down, it's not an issue. You lead an ordinary life. What you don't do is you cannot eat large amounts of food. You eat little and often. You graze, as the expression is the best way to do it. And the best way also to do it is not to eat foods that require a lot of, I'm not sure the right phrase, digestive energy. If foods require, everybody can feel tired after a meal because your digestive process is taking up energy. I think that's what happens. And that's why people sleep in the afternoon sometimes or whatever. But if I eat little and often, it drains the energy levels less. Whereas if you eat a big meal, it wipes you out. And that is definitely a consequence of it. Something else I can't remember. Jog my memory, jog my thoughts. Let's have a look. Psychologically, emotionally, there's the usual system with cancer is 5 years, and if it doesn't come, the graph for my cancer is is like this. This is 0 years. This is 5 years. It goes like this. The first 2 years, the incidence of reoccurrence and death is still there. After 3 years, it virtually becomes nothing and disappears. So after 5 years, medical authorities tend to you're finished, you're done, you're recovered, and any new cancer that arrives is a new cancer. And I'm well beyond the 5-year period, and the cancer's gone. And I have to say, I have never been that concerned blindly, naively about the cancer. The issue has always been for me the surgery and the effect on me, because it's always there. You know that you've had a major reconstruction inside you, and I have a sensitivity in my abdomen as a consequence of it. I can feel a sensitivity. Yeah, and you do worry that there might be something that could go wrong inside you. Not the cancer, ironically, but actually the post-operation implications, which, unlike me, I have never really read up on research, because part of me doesn't actually want to know some of that stuff, because there are quite a lot of things. Like, I wish I didn't know what the word fistula means, and I do. And I think another one is anastomosis, if I'm right.
Yes.
Which is pretty nasty. I seem to recall reading. That's it.
Great. Bob. Thank you very much for your insights. I've got a last question for you. I think you've got the really very best possibility of therapy available. You got this operation, all went good, but I think now in the future, if a medically proven device containing these artificial muscle and the anti-reflux valve would exist, would you say that would be an alternative for you, or for other patients who come?
I think definitely. Bearing in mind the process I described of meeting with the oncologist and the surgeon and everybody else, you would be obviously, you go into these situations, 99%, you're ignorant, you know nothing about the scenario. It's a brand new experience for you. And it's cancer. And therefore that has significant anticipation and concern. You'd want to really talk it through with the surgeon, what this would be, what the implications would be. I think the very fact of an alternative option, which, as you recall in my story, I didn't have one, would lead to questions, discussion, debate about the right way to go. You'd have more of an exploration of what could happen. The idea of inserting something inside the body is not one that you necessarily warm to say the least. It would be of concern, and you would want to question and query, what does it mean? What's the big thing, looking back retrospectively, would be how much does it reduce the risk of things going wrong? The surgery I undertook is extremely complicated and has significant risks in it. And if it lowered the risk of that, and then lowered the risk of complications afterwards, it's not just about quality of life, because my quality of life is fine, but affected. It's about the risk of things going wrong, the risk of things developing, which inevitably with major surgery there will be. I don't know the stats, but I'm quite sure there are quite significant numbers of people who end up with complications as a consequence of the surgery. If this was to reduce that or remove some of it, then it would be an absolute boon.
Perfect. Hilmar, could you please, in 2 or 3 sentences, give us an aspect, what the special features of this artificial esophagus would be?
I think. No, it's okay. The question is fine. It would need. What are the implications for me now? I would like. This is ideal. I would like just to be able to eat and sleep as I would normally do, and I would like to know that piece of kit inside my body reduced the possibility of other things going wrong. If it had risk factors in itself as well, then they must be balanced against the existing risk factors. But I can't imagine, considering the complication of the surgery, that a device in there wouldn't be anything but beneficial in terms of the quality of the nature of the whole living and eating process.
Right.
Okay.
Okay, then I would jump on your question, Peter, once again. The artificial esophagus we are working on does have all these functionalities integrated. So you can eat simply as you do it today. You have a reflux valve. You are able to vomit. And the only disadvantage you have to change some from period to period the battery.
That would be a good example, I think. I wouldn't like to do it. It would be a pain because it's a permanent reminder of the issue. And, oh, God, I've got to go for that hospital appointment again, is what people's responses would be. Mm-hmm. But then I remind myself, remind yourself about your first cancer appointment. It's not something you wanted, but you had to do it. So this to be honest, I think is in those categories. Yes, it's a choice scenario, but it's, if you don't do this, what's the option? It's not just about perfect world and doing this. It's about a very imperfect world and having this device implanted in you and the battery scenario. So I think you'd balance that up and probably live with it and say, okay, that's what goes with the deal. That's part of the package. That's it.
Great.
So thank you very much for your comment, especially the last aspect we asked to you. Thank you.
Okay, so
thank you very much. Appreciate.
Thank you for all of you, especially Bob. You wanted to add something?
I'm sorry. I should have got it in there. Forgive me. Earlier on, I couldn't remember something. And what I couldn't remember was the fact that you cannot vomit. That is is an issue I should have mentioned earlier. And Hilmar just mentioned it. I mean, how many times you need to vomit? Not too many. But when it happens, you can't. It's actually, it could be significant for some people at certain times. Forgive me for that digression right at the end there.
It's no problem.
Okay.
Our valve will allow to give you back this feature, let me say. So thank you for all of you, my colleagues, and especially Bob, for sharing your insight. And I hope to see you soon back here in France.
I'm trying to organize an appointment with my surgeon in Perpignan for a follow-up. And I've discovered, guess what? He's gone and moved to New Caledonia. I asked him, New Caledonia. He's got it sorted. I think he's got it sorted. But okay, I will be there shortly, Kerstin, I hope.
Okay.
Thank you.
Then.
Thank you both
so much.
Nice
Bye.
Thank you, Hilmar.
Have a nice day.